Okay, now we're going to get started on H2 blockers. But before we get started, we need to talk about prevention and teaching nursing implications for people that have even occasional heartburn, reflux, or even have an active peptic ulcer, a duodenal ulcer, things like that. So what are triggers? So triggers, let's think about your diet and things like that. So obesity can relate to that. So obesity, smoking, eating large meals, sometimes drinking alcohol can do it, drinking soda, chocolate, peppermint, coffee. All of those are triggers for heartburn. So make sure you write all of those down. And then what are we going to do to teach the patient? So we're going to basically teach them to stay away from all those. We're going to have them eat small, frequent meals, about 5 to 6 small meals during the day. Is that always realistic? No, but it really does help to eliminate or decrease that trigger for reflux, because if you're eating large meals, that sphincter at the bottom of your esophagus doesn't always function as properly, and if you're eating large meals, it just gets stuck between the sphincter and then comes up. Stopping smoking, so that's a huge teaching thing to do. Talk about small goals with some weight loss, staying away from sodas, anything with carbonation, stay away from alcohol, coffee, chocolate, peppermint, all the above that I said. So make sure you write that down. So basically, you have to take away all the things that you enjoy, right? Not fun. Okay, so we're going to get started. Looks like there's a delay. Okay, so hopefully this whole thing will show up on the screen here. All right, so what do H2 blockers do? When I say H2 blockers, I mean the H2 agonists. And sorry about my dog. Oh my gosh. Okay, I'm going to close the door here. Hold on. All right, what do these do? These reduce acid secretion. So it's a little bit different than the last one we talked about with your antacids. These reduce the acid secretion, whereas the antacids neutralize gastric acid. So please keep those two in your mind, write them down. The H2 blockers reduce the acid secretion, and the antacids, which would be like your milk of magnesia, for example, they neutralize the gastric acid. Okay, so going back to the H2 blockers, you can get most of them over the counter now. They used to be prescription, but not anymore. And some examples are your Tagamet, Pepcid, and Zantac. The most popular being the Zantac or Pepcid. Tagamet reacts with a lot of different drugs, so I usually tell everybody to stay away from those. Stay away from that particular one. Okay, so what are they for? They're for GERD, gastroesophageal reflux disease, peptic ulcer disease, erosive esophagitis, which explains it's eroding through the esophagus, which you're at risk for a bleed. You can use it to control upper GI bleeding in adjunct with like a proton pump inhibitor, which we'll be talking about next. But proton pump inhibitors are your Prevacid, Nexium, Acifex, and those types. Also, there's some pathological conditions, Zollinger-Ellison syndrome. You don't have to worry about that on your test, but you may want to look it up. It's just a specific condition for that. All right, so there's not a lot of side effects to this except for the Tagamet, which again, I usually don't recommend it, but just please know this, that it can induce impotence or erectile dysfunction is actually the correct term for it, and then gynecomastia, the enlarged breasts in males, so which turns into like an endocrine thing. So I really, keep that in mind and try to avoid cimetidine. So make note of that. Sometimes you get some headaches, confusion. I've never seen that happen with any of these drugs, but just know that those are some side effects that can happen. And if they do, then you're going to going to tell them not to take that medication. Okay. So more about the cimetidine. So what it does, I know we've talked about the P450 that's in the liver. It's a pathway where the drug gets metabolized. And so then what it can do is it can have other medications that are going through that same pathway not metabolize correctly. All of these H2 blockers can inhibit absorption of drugs that require an acidic GI environment for absorption. So there's been a lot more studies out within the last 5 or 6 years saying maybe it's not good to be on these chronically, which it really isn't, but there's some people that have to be on them chronically, especially your proton pump inhibitors, because of Barrett's esophagitis, which should have been in the slide, but it wasn't put in the slide. So let's go back to here. Write down Barrett's esophagitis. So basically what Barrett's esophagitis is a precursor to esophageal cancer. Anybody that has Barrett's esophagitis really needs to be careful and make sure that the acid is neutralized and decreased as much as possible. Because think about this, your stomach's supposed to be an acidic environment. That's where the acid's supposed to be, but sometimes you end up getting reflux. Well, if it's not controlled, what happens is that esophagus, that's a neutral environment, the cells start changing and it can turn into an acidic environment. It's not supposed to. And that's where you can get those precancer cells that turn into cancer. Those precancer cells are Barrett's esophagitis. Sorry for jumping back, but I thought that was important for you to know. Smoking has been known to decrease effectiveness of the H2 blockers. So not only is it a trigger for heartburn, it also decreases the effectiveness of taking any of these medications, the H2 blockers in particular, because it increases gastric acid production. So smoking's just not good at all. Make sure that they, obviously you're going to check their allergies and check their renal function, liver function. Make sure you use cautionary with confused, disoriented, or elderly. There's a higher incidence of central nervous system side effects. You want to take these 1 hour before or after an acids just to make sure that they're working efficiently, because you're taking an acid, you're neutralizing it, the gastric acid, but then those start wearing off, so then that's when you would take your H2 blocker and decrease the gastric acid that is reformed. You can give these IV, and in the hospital you will see this as protocol sometimes. All right, now we're going to go right to proton pump inhibitors. So what are proton pumps? So you can read these, but basically proton pumps are in your stomach, and they control the acid that's being secreted out in your stomach. And so proton pump inhibitors basically shut down these proton pumps so you don't have the acid coming out all these proton pumps. So the whole point is to decrease that and to stop it. People with Barrett's esophagitis need to be on proton pump inhibitors because we don't really want as much acid going in the stomach, although it does cause problems with, as I talked about in earlier slides, with medications not being metabolized as appropriately, but you have to weigh the risks and the benefits. So what it causes is neutralization of the gastric acid. That's a roundabout way of saying that. And this is just a picture, and it shows you the proton pump and how it blocks the proton pump, blocks the acid, and so therefore not as many will come out and produce acid. Okay, so let me go back to this last slide. I want to put my screen down here. Ugh, maybe it's not going to work. Okay, anyways, so on this side here, hopefully you can see my cursor, the pH is higher, okay, and then here the pH is lower, just to let you know, okay, because this is extracellular fluid, this is cytoplasm, but an easy way to understand it, that when you're blocking these proton pumps, you're not going to get as much of acid being secreted from that because it's being completely blocked. All right, so what are some examples? We have Prevacid, Prilosec, Acifex, Protonix, and Nexium. Those are out, all out over the counter except for Protonix. It's the only one now that's a prescription. They're all made in very similar ways, but again, just like the H2 blockers, some are more particular with certain side effects versus others. The Prilosec is I don't know why that's starred. Maybe at the time it was the only one over the counter, but certainly all of them except for Protonix. Omeprazole, the Prilosec, was the first one over the counter. It's been out for a long time. So it's for GERD maintenance therapy, erosive esophagitis, short-term treatment of active duodenal and benign gastric ulcers, Zollinger-Ellison syndrome, and H. pylori. So H. pylori is a bacteria that thrives on acid, and in order to treat H. pylori, you need proton pump inhibitors along with some antibiotics and Pepto-Bismol. There's some different treatments for it, but that's one of the main treatments. People need to take this because they need to completely shut down the proton pumps. You don't get that acid. It helps heal ulcers because now you're not having that acid eat away at an ulcer. That's what caused it in the beginning. And then obviously the erosive esophagitis, people that have GERD, especially the Barrett's esophagitis, need to be on those permanently. Side effects, they're really safe for short-term therapy, but now we've been finding out people that take it long-term, again, they're having issues with some meds even working that's going through the GI system. Again, it's weighing the risks and the benefits. What happened when these drugs first came out, they really have not been taken as prescribed. So you have people on it for years for reasons that they really don't need to be on it. But now what happens is it's hard to get off. This is a drug you have to wean off because think about it, shutting down all the proton pumps. If you stop it immediately, it turns all those proton pumps back on and you have this you can have like a rebound effect even, and overproduction of acid, and then they're miserable. So you really have to wean them off very carefully. Same thing with the H2 blockers, make sure they don't have any liver disease. And the Protonix is the only proton pump inhibitor available for the IV use. And it's used for patients who can't take oral medications, but it is used commonly in the hospital for specific protocols that they have. It may increase your Valium serum levels of Valium, so be careful with that. Phenytoin, which is your dilantin for seizures, and it can cause increased chance for bleeding with warfarin. So anybody on warfarin, you're going to check every single med they're on. Warfarin interacts with most medications out there, so it's figuring out, all right, now you probably have to adjust the warfarin dose with the proton pump inhibitor if that's the case. You can't say, oh, you can't take warfarin, but you had a stroke. You put them on the warfarin, but they may need a lower dose. Okay, so make sure this, one thing to remember with the proton pump inhibitors, it works best if you take it about 30 to 45 minutes before a meal, and then you take the meal, and then that's how it's activated. It comes in capsule form. Make sure it's swallowed whole, not crushed, opened, or chewed. You can give this with antacids, and the whole thing is to tell them that the treatment will be short-term. But again, there are some people that are on it long-term, but the way it's supposed to be taken for, say, healing ulcers, or just a short burst of just reflux without that Barrett's esophagitis, you can take it short term and then you should stop it. When I say short term, it should be about a month. That would be short term. Just to give you an idea of what I do in practice and what guidelines are, if someone comes in with heartburn that has tried the acid neutralizers, which would be your milk of magnesia, etc., over the counter, and has also tried your H2 blockers, then I will say, all right, let's try a proton pump inhibitor, put them on, you know, like an omeprazole, the Prilosec or Prevacid, something over the counter, and they have to come back and see me in 3 to 4 weeks. If things are not improved taking a proton pump inhibitor, they go to the GI department or a GI physician, because that tells me that maybe there's something more going on. If they respond to it, I take them off it and they follow back up within about 3 to 4 weeks. That's best case scenario. Some people with insurance, they don't come back, but that's what they should do, because if it's worse, then after stopping it, they should definitely follow up. Also, I want to clarify, when I say it takes a while to get off of this medication, if you just take it for a month, you're not going to have those side effects like if you were taking it for a year or years. All right. Before we start on these here, I want to go back. Okay, so something to take note of for proton pump inhibitors. Remember that the proton pump inhibitors completely shut off the proton pumps to secrete acid. Okay, remember that. And so what, in the fancy terms, it's inhibiting an enzyme that makes the gastric acid. Those are your proton pumps. So if somebody has a duodenal ulcer and you want to treat them, they should always be on a proton pump inhibitor. So you really need to take some flashcards, or get some flashcards and make your proton pump inhibitors and write them all down. Your H2 blockers, write them all down. And then write down your neutralizing gastric secretion ones, like milk of magnesia, Pepto-Bismol. I would do that because for testing purposes, and this stuff is so common that you really need to know these. And you may already know a lot of these because you see them over the counter or have seen commercials for them. The other thing I really want you to take into account is the elderly with any of these medicines, but particularly the proton pump inhibitors. They have a lot of medication interactions. Also with elderly people, which these aren't in the slides, but you really should know this is important, that it can, they have increased risk for osteoporosis. And most likely because you can have some vitamins that you're eating that may not be metabolized as well because you're taking the proton pump inhibitor. But you can have some vitamin mineral deficiencies, the osteoporosis, and some medication interactions. So with the elderly, again, you got to watch with any medication, but particularly that. All right, so there are 2 other drugs, which is sulfsucrol, I'm not even going to say it, Carafate, and then the Cytotec. All right, so I'm going to talk particularly about the Carafate. The Cytotec, it can be used, although it's not used as much anymore for ulcers. But let's talk about the Carafate. Some people even say Carafate is more of a placebo type medication that basically just coats the stomach and psychologically makes you feel better. It comes in this thick white liquid. Also can come in some tablet form that tastes kind of chalky. But it can be used in conjunction with, hold on. Okay, sorry, I had to put it on hold because my dog was barking again. Oh my gosh. Okay, so if anything, this will get your attention again, right? If you're falling asleep at this point. All right, so for the Carafate, it should be taken in conjunction with something. It really doesn't, this is what it does. It adheres to the ulcer and blocks the back diffusion of hydrogen ions. That's the fancy term of that. So write that down. It adheres to the ulcer and blocks the back diffusion of hydrogen ions. So basically it's supposedly trying to prevent those hydrogen ions from coming through by coating the ulcer, therefore not getting that acid in that area. You really should take this an hour apart from most medications, especially if you're taking antibiotics. It does not have any systemic side effects. It's really just working in the stomach. It does not have any acid neutralizing capacity. So it doesn't do anything with neutralizing the acid whatsoever. So it's a very old drug. It's been out for a long time. Why would we use it? Well, let's say someone has a peptic ulcer from H. pylori bacteria. So then there's that whole regimen I talked about, and one of them you could give the Carafate with your Cipro to help treat it. But if somebody needs to take that with the Cipro, you make sure that they're taking it 1 hour apart. I just talked about this, but just remember what I told you to write down. And I talked about how there's low absorption of the gut. I guess I talk ahead of myself. It's really rare that it would cause constipation, nausea, and dry mouth, although it can. It can impair absorption of other drugs, especially tetracycline, although it'd be rare that you're taking tetracycline. It's not given out as much. But to remember with the Cipro, with the peptic ulcer disease, which would be a common regimen to take with the H. pylori bacteria for treatment. All right, so the Cytotec is a prostaglandin analog. It protects the gastric mucus from injury because what it does is it increases the mucus around the area to protect it. So it doesn't really have anything to do with acid, but more or less protects the gastric mucosa area. But we're not really going to talk anymore about that. It's used for prevention, although it's not really used too much anymore. So that's all I'm going to say about that. You don't need to know that for testing purposes. I'm going to talk about antidiarrheals and laxatives in another session. Let me go back because I just don't pay attention to the slide. I want to do a quick review here. So remember to know your proton pump inhibitors versus your H2 blockers versus your antacids. Remember exactly what they do and what they are. Remember with your cimetidine, your Tagamet, you have to be careful how it can cause gynecomastia. So you have to look at history. And I usually don't recommend Tagamet, but some people do take it, and you have to make sure that they don't have gynecomastia or it can interact with some other medications. All right. Another thing that's real important to know that Pepto-Bismol in the and I mentioned this in the other set of slides, but just remember your Pepto-Bismol has salicylates in it, which can cause your stools to be black. Talking about H. pylori, which is the bacteria that's in your stomach, there's different ways that you can test for that. One way is a breath test. You just have them breathe into some sort of contraption and then you test it for H. pylori bacteria. It's actually supposed to be the most accurate way to check for H. pylori other than actually getting a biopsy from the stomach area. So what would happen is you do the breath test and it would come out positive, and then they need to go on a treatment medicine, which would be antibacterial medications, which is primarily 95% a cause of peptic ulcers, not duodenal ulcers, but peptic ulcers. So how it really works is for the breath test, the patient is given radio-labeled urea, which converts to carbon dioxide and ammonia if H. pylori is present. And this carbon dioxide can be detected in the breath. So just know about the H. pylori and the breath test. If they've been treated, they can do a post-breath test and it should be negative. To make note of with Pepto-Bismol, not only can turn your stools black, but it can also turn your tongue black. So I have had countless times where patients come in freaking out about the black tongue and they think they have blood in their stools, but it's really from the Pepto-Bismol. The other thing is, what if somebody came into you and said, you know, I'm taking these NSAIDs here. Is there anything I can do to prevent an ulcer? What's the best drug that you would put them on? If you want to prevent an ulcer, really the only thing that's going to help, the best medicine that's going to help is your proton pump inhibitors, because you want to shut those down and really try not to have as much acid go through the GI system.